Welcome everyone, and thank you for joining us for this month's LSVT BIG public webinar. The that we'll be going over today is on deep brain stimulation and LSVT BIG, mobility challenges and treatment solutions. My name is Lori Gousset. I'm a physical therapist and one of the LSVT BIG training and certification faculty, joined by my colleague Heather Ciance, who's also a PT and an LSVT BIG training and certification faculty member. So we welcome you, and we hope this next hour will be very fruitful and answer some questions that you might have. So briefly, here are our bios. I won't read them directly. However, Heather and I have both been therapists for many years and have been certified in LSVT BIG respectively since 2009 and 2007 for Heather. So we've had many years of experience providing LSVT BIG to our patients with Parkinson's and other neurological disorders. And we're just delighted to be able to share our clinical experience and knowledge with you, whether you're a person with Parkinson's, a caregiver, or maybe a therapist joining us in today's webinar. Some brief disclosures that we always provide at the beginning of any of our lectures or webinars: that we both have a non-financial relationship for LSVT BIG, including a treatment preference for LSVT BIG as a treatment technique. I myself am an employee of LSVT Global, and both Heather and I receive consulting fees and lecture honorarium from LSVT Global. If you are a therapist joining us for today's webinar, we just want to give you a little bit of information that these webinars are not state registered for CEUs, but if your state allows for self-report of CEU credit as non-registered CEUs, please email us at webinars@lsvtglobal.com, and we'll be happy to send you an electronic certificate, which will include your name, date, and duration of the webinar. The same rules would apply if you're a speech therapist joining us today. You do have to attend the full hour to earn a certificate. If you're an LSVT BIG or LSVT allowed certified clinician joining us today, we'd just like to remind you that the same topic in more depth scaled towards clinicians are available in your LSVT clinician account as on-demand webinars. We just recently did one, in fact, for LSVT BIG clinicians specifically on Monday, and a different one for LSVT Lab on a different date. Here's briefly the plans for today's webinar. Both Heather and I will be presenting part of the content. Heather will take the next series of slides and content and present that to you. And after she presents, I will present as well. And at the end of the webinar, we'll have time for your questions and answers. So I will remind you at the end of how you can ask questions live during this webinar, but I'll tell you right now as well. On your control panel, you might see that you can type in a question. You can submit those questions at any time. We'll stockpile them and answer them at the end of the webinar. They are anonymous, and that will not disclose your name or anything about you when you ask those questions by using the question feature on your control panel. The other way that you'll be able to ask your question is out loud. So if you want to click on the hand icon at the end of the webinar, we will see that you have raised your hand. We'll call out your name out loud so that you know that it's your turn, and you'll simply unmute your microphone. We'll also unmute your microphone from our side, and then you'll be able to ask either Heather and I a question related to this topic. You'll also see in your control panel that there is a handout for today's webinar. This is a handout of all the slides that you'll be seeing. So if you want to save that, download it for future reference, you sure can do that. This webinar will be recorded and available on our blog in about 1 day. So if you want to go back and review anything or share it with someone else who you think might be interested, that'll be available shortly. So the main content of our webinar is going to be discussing the application of LSVT BIG to individuals with DBS surgery, and we'll also go over really what DBS is and how that could impact movement both positively and negatively. At the end of the webinar today, a survey will automatically launch And it'll just take you a few minutes to complete that survey. Our learning objectives are these. By the end of this webinar, we hope that you'll be able to describe the use of deep brain stimulation, what we'll be calling DBS, in Parkinson's disease, identify who's a good candidate for DBS, and also associate the use of LSVT BIG treatment in combination with DBS. And with that, I'm going to turn over the mic to Heather, who's going to walk you through the next series of slides.
Great. Thank you so much, Laura. I appreciate that introduction. So I want to let everyone know, while Laura and I are going to be talking about deep brain stimulation, this is an overview of this. Of course, the decision to ultimately have deep brain stimulation is a personal one for the person living with Parkinson's disease, as well as their entire care team. So and we are in no way suggesting that this is a practical solution for everyone living with Parkinson's disease, but when it is something that is made in a really honest and open way, with your whole surgical team, your medical team, it can be very helpful for many people. So we're going to start with talking about, what exactly is deep brain stimulation, or DBS. What you need to know is this is a surgical procedure, and it's used to treat a lot of the disabling symptoms of many neurological disorders, including Parkinson's disease and essential tremor. And the symptoms that DBS is really used to help with can include things like rigidity, that tightness feeling, that kind of cogwheel motion when the doctor goes and bends and straightens your elbow. It also helps with the symptom of tremor. And we know that tremor can be very, very disabling for people. Always starts on one side, progresses to the other side, and really can impact things with the ability to get dressed, to eat, to carry items. And then the last symptom here is dyskinesia. And dyskinesia is a side effect of long-term use of Sinemet. And those are those involuntary kind of extra writhing movements that you often see people making. I like to reference my folks to Michael J. Fox. He is a good example of what dyskinesias look like. Now, I said that this is a surgical procedure, and there's actually 2 points of contact where surgery happens. And the first one is where they actually place a battery-operated device, which is known as a neurostimulator. And that's actually the battery pack that kind of charges and stimulates that lead that's going to go to the brain. And that neurostimulator is very similar to a heart pacemaker. It's about the size of a stopwatch, and it's placed directly under the skin near individuals' collarbones. There are cases of people having it placed in different areas, but the most common place is right there near the collarbone. You can actually touch a person's chest, and you can feel where that stimulator is. Now, the second point of contact is a very thin insulated wire, and that can be called either a lead or an electrode. And that's actually inserted through the skull, where there's an actual hole that's made through the cranium, and it is inserted through the skull to a targeted area of the brain. And we'll talk a little bit more about those areas of the brain that are decided upon by the neurosurgeon. And that then sends the electrical impulse to that actual part of the brain, and it really helps to interfere or block the signals that cause those PD symptoms, whether it be the rigidity, the tremor, or the dyskinesia. Next slide. So what we're looking at here is a little picture, and I want you to notice down at the bottom there, that's the neurostimulator. That's the part that I was talking about that's placed under the collarbone. That's where the battery is. You can follow the small thin wire that goes up here. It's called the lead. It passes around, it goes through the skull, and then that little electrode is the point of contact that's touching that targeted area of the brain. And there are 2 main areas that neurosurgeons use, and we'll talk a little bit more about that to help to kind of disable or disarm those symptoms. Now, what's going to happen next is Laura is going to pull up a slide that actually has a video contained in it, and we're going to see a little video about DBS, and this might be very helpful for you. So go ahead, Laura. Great. Thank you so much, Laura. So I think that video gave you a really good idea of kind of where that is placed and how it goes, as well as looking at that picture here. So this information is taken from the Parkinson Foundation website, and it asks or tells people, when people are asking, am I a good candidate for DBS? It kind of gives people a general idea of, would I benefit from this? Can I do this? And what they've listed here is one of the first ones is generally people have had to have the Parkinson's for at least 5 years. Part of the reason for that is there's a lot of trial with doing different medications and different treatments. So they want to make sure that they've kind of exhausted many of the different things that are out there prior to going into the surgery. And they're looking for people who have what we call on and off fluctuations. And that's despite even having their regular medication, and the medications are kind of doing what they need to be, but they're not lasting as long. So, oftentimes in the beginning, people would be given their carbidopa, levodopa, also known as Sinemet, maybe a certain number of times a day. And then maybe the amount of time between those dosaging gets smaller and smaller, and people are taking more medication. And with that medication not lasting as long, they have what we call off times. And off times are when the medication isn't truly working its best, where people may be experiencing more rigidity, more tremor, episodes of freezing of gait, more episodes with difficulty with being able to concentrate, areas also where they get highly kind of anxious. And then when the medication's working and it's on, they feel pretty good. But this inability of having a really nice, long-lasting on time can be very disabling for people. Also the patients who have dyskinesias, which I mentioned before. And there also are a class of people living with Parkinson's disease who unfortunately really cannot tolerate the anti-Parkinson's medications due to some of the side effects. And that could be something like nausea, many different side effects that may keep people having the ability to actually use them. And again, if there are people who are suffering from a really severe tremor, and that tremor is not being well controlled with medication, even with kind of medical management by their movement disorder specialists, again, the DBS can be very beneficial for that. They're also looking for people who are still having a good response to that Parkinson medication. So that means that carbidopa, levodopa, or Sinemet, meaning that when they are on, the medication is working well and they're able to move around, they're able to do the things that they want to, although the amount of time that that medication is actually responding to them may be less and less. So a less sufficient ideal operation of movement for these people. And also for patients who have tried very different combinations of anti-Parkinson's medications, and that is through under the supervision of their movement disorder neurologist. There are numerous classes of medications that can be tried, and sometimes there comes a point where it's really kind of tricky to manage those and they're not getting the full effect that they want to. And then, of course, if those symptoms of the Parkinson's disease are really interfering with those daily activities of living, people's ability to get dressed, to get out of bed, to be able to eat a meal, to continue to be able to stay employed, to care for family members, those are all of the things that they're really looking for when they start first making that decision, thinking about who would be a candidate for DBS. Next slide, please. It really is a multidisciplinary team. You really do have to enter into this with a solid foundation of people who are really kind of looking out for your best interests, people who are communicating with one another, and people who are really making honest and educated decisions about this. So first of all, that medical team, your neurologist needs to be in contact with your neurosurgeon. That doesn't mean that your general practice physician is out of the picture. They need to be involved as well, and sometimes even your dentist, because we need to make sure that people don't have any kind of dental infections going on. We need to know that all of the medications people are taking. We need to make sure people are healthy before they're going to have surgery. We're involving nurses. We're involving certified nurse practitioners and PAs, sometimes a physiatrist or a rehab medicine doctor, and of course the pharmacist as well, in better understanding the medications. And then as well as combining in the allied team professionals. So that is speech language pathologist, physical and occupational therapist, clinical neuropsychologists, social workers, and sometimes even centers have nutritionists. At the center where I work, we do have a DBS clinic, and that is where People with Parkinson's disease are brought in and they are tested off their medication as well as on their medication. And they're seen by PT, OT, speech, social work. They're seen by the neurologist. And there's lots of testing that goes on. So we're really trying to look at, what could be some of the potential issues that might actually not make this person a good candidate, and what are some of the things that actually are helpful to this person. And we're thinking that, this person would be helped through the DBS. So again, staying on top of really having all the members of your care team working with you is really going to be the best situation for you. Next slide. So I mentioned before about the target selection. Where will that neurosurgeon actually implant that electrode? Two of the most common areas right now are the globus pallidus interna, which is the GPI, or another area called the subthalamic nucleus, and that's the STN. So both of those areas of the brain, the motor benefit, meaning the control of those symptoms and how people are moving, is really similar with both of those targets, meaning that both of them can actually have a really nice improvement on lessening dyskinesia and also improving patients' quality of life and how they're moving. Now, what we found out over years and through research and watching people is that the DBS of the subthalamic nucleus offers a little bit of a greater dopaminergic medication reduction, meaning that some people can actually come down off of some of their medication. And there might even be a possibility of some minor benefits in the non-motor issues that people are suffering from. Now, when we're talking about the DBS being implanted in the globus pallidus interna, we're looking at it providing a probable advantage in that dyskinetic suppression and management of symptoms with the unilateral leads. And that means that sometimes you can have just one of the neurostimulator, the battery packs, and then actually have just one lead that goes up to one part of the brain. So not actually having one on each side. And also finding that there is flexibility in the use of the medication and being able to program that neurostimulator and knowing what, how much of that stimulation is going to go. And they found that overall, the subthalamic nucleus DBS is potentially higher or of equal risk for neuropsychiatric changes when we compare it to the GBI. So sometimes we're finding that there are more side effects longer term from one versus the other. And this is why it's so important that you're talking with all members of the team to really have a good understanding of what the best area for that target implementation is. Next slide. So a lot of people will ask us, this is brain surgery. This is a big deal. I mean, it's kind of scary. It's kind of ominous. What's going to go on? And the really good news is that the length of stay following that deep brain stimulation surgery is really, for the majority of patients, very short. People come in, have the surgery, and may only stay one day, and they're discharged home. The reasons that most people will stay a little bit longer is people may have some sort of a mental status change, they may be a bit confused, may have some issues with that, or may have some hemorrhagic bleeds. Now, those who have been delayed in getting discharged, so the folks who stay a little bit longer, those are the people that before the surgery was even performed, they had a little bit less of a score on some of the cognitive screening scores, meaning that they scored a little bit less, so they had some more cognitive slowness, some more processing changes. And those folks who were, when they were on, they had a higher on motor score. And then the folks who are really also staying later might be the folks who the neurosurgeon had to kind of move the microelectrode a little bit more. So they're doing a couple of passes to kind of find the right spot. They don't find that right spot maybe on the first time. And that might be some of the reasons why people will stay generally a little bit longer. But in general, the patients that I see are really happy with the length of stay of going in, having it done, and being discharged home that next day. Next slide. So again, as with any surgery, there is always a potential risk and potential for complications. So although these numbers are low, they are important to be aware of. People can have intracranial or intracerebral hemorrhage, and that's a bleed. There can be a risk of having a stroke. There's always a risk of having an infection anytime we implant anything into the body. So you can see that scores a little bit higher. There's a small percentage of patients who actually have seizures post-implantation of the DBS. There may be some increase in suicidal thoughts following DBS. And we know that when we follow people for a very long time following the DBS, we do know that there are declines in cognition over the long-term use of the DBS. And for some people, unfortunately, you can end up with a worsening of your speech and your gait and balance after the DBS. Next slide. So post-operative programming, again, this is a big surgery. It's brain surgery. You feel like I'm going to go in, they're going to kind of zap my brain, they're going to make it work, and then I'm going to go home. Well, that's really not the case right now. It is that the stimulators and everything are actually put on into that brain of that patient. But what we're finding is that we don't send them home with that on anymore. So the initial programming actually is going to take several weeks after the implantation, because what we're calling a lesion effect. So it's almost like a placebo where the brain is kind of excited from what's going on in there. And sometimes people actually feel like they're moving better and feeling better just from having that electrode in the brain, even without it being turned on. The most effective electrode configuration is really what's going to give the most benefit with the least amount of side effects. So there's a lot of trial and error with how they are programming and tuning these DBS. The amplitude of the stimulation is always started relatively slow and gradually increases over time. And that really does help for people to allow for the potential in having their medications actually come down as well. And again, with less medication, then we have less of the side effects that go with the medication. And generally for optimal programming, it's going to take anywhere up to 6 months and may require several sessions. So it's not infrequent for patients to be coming in multiple times over that 6-month follow-up until that person who is doing the programming really gets it to the best level for each individual. Next slide. So when we're looking at outcomes, what happens to people after DBS? We're looking at the research, and DBS really has been shown to be superior to just medical management, so better than just having medication. And it really did increase the amount of on time. So the time where you're feeling your best, the medications are working, you have the best movement and the least amount of dyskinesia. You can see that people really have gained an average of 4.4 to 4.6 hours of that. And there's a scale that the neurologists and neurosurgeons use called the UPDRS, which is the Unified Parkinson's Disease Rating Scale. And that takes a look at different motor scores. And they're showing that people, even when they're off their medication following the DBS, they're able to have better quality of movement, as well as you can see here some improvements in sleep and in quality of life. And we know that everybody who gets better sleep always feels much better. Next slide. Now, of course, we're saying all these different things that DBS is really helping with, but we also need to have an understanding of, what can it not change? What things are going to kind of stay the same? So really, how does DBS affect those symptoms of Parkinson's disease? We mentioned before that it can really reduce or control the rigidity, the slowness, the tremor, and the dyskinesia. But you have to remember that the patient is only going to return to their best on time, meaning that before having the surgery, when you were taking your medication, the best that you were moving when your medication was working is really the best that you can hope for following that DBS. There are studies out there that are suggesting you can reduce the amount of medication needed by upwards of 30%. But unfortunately, we do know that the subthalamic nucleus implantation of DBS has been shown to lead to issues with depression, with apathy, impulsivity, some worsening of verbal fluency, and executive dysfunction. So we need to remember that there's things that happen with the body that keep going on even though we have the DBS. So here's a wonderful survey by the Parkinson Alliance that talks about fear of falls and falls with people with DBS. And it was a huge study looking at over 300 people with the DBS and over 800 without. They represented all 50 states, and they had a good blend of older and younger people. What they found was the people that actually had the DBS, who you would think, they have less signs and symptoms of Parkinson's, they should be doing better. They actually found that those folks had a greater risk of falling, and that those folks were actually having more falls, they were fearing falls more, and they actually were reporting that they had more difficulty with their mobility their speech, and also felt some stigma. So let's look at the next slide and we'll talk about why those were the reportings from this survey. And I want to read this to you because it's really important. It says that individuals with DBS therapy may have the extra ability to move without functional impairment, but they lack the feedback and the control to do so safely. And that means that people might be more confident and might be more capable because they don't have so many of the symptoms. But even without those symptoms, people do neglect to attend to what and how they're moving. So, you know, you may be able to still now move with more freedom of movement, but you lack the control. So you may still be impulsive. You may still have issues with balance. So it's really important that even though we're getting more motor punctuation, we have to make sure that we're still looking at the reason why people are falling and the reasons why people are having difficulties. Let's take a look at the next slide. So these are some of the things that are different after DBS and why people would continue to need therapy. And something like LSVT BIG is, although that we've given them increased freedom of movement and increased extension of posture, oftentimes people have very wild, uncontrolled movements where now they're moving, you know, they had this slow, stiff body that now they're able to move, but they're not really sure how to control the movement. And oftentimes that movement can get too big. And when you have that, you really can then have those risks for falls, as well as speech being negatively impacted. That's where someone might actually need to have LSVT loud for the voice therapy. Next slide. So we have to remember that the DBS is not a full cure, and that although the improvements that we see in this don't lead to a systematic improvement in all aspects of quality of life, and it doesn't improve all levels of activity. And this highlights the need for us to really develop and implement intervention strategies to promote an active lifestyle in this population, even if clinical improvement is evident following surgery. So we still do recommend that people are seen by physical, occupational, and speech-language pathology pre and post DBS. So now I'm going to turn this over to Laura, and she's going to talk to you a little bit more about how we use LSVT BIG for people who've undergone the DBS.
Okay, thank you so much, Heather, for that great overview. You were talking a little bit earlier about the improvements that people can expect after DBS, on top of the improvements they might see with their medication. But really, I think when you and I both talk to our patients, it's a combination of, you know, optimal medical management, whether that be the drugs that they take, sometimes neurosurgical interventions like DBS, paired with evidence-based voice and body exercise like LSVT loud and LSVT big. And that we feel, based on our clinical experience and years of research, is really what optimizes a person's function with community and mobility and activities of daily living in everyday life. So before we talk about LSVT BIG and how it's used to manage symptoms of Parkinson's disease to improve function before or after LSVT BIG, I think it'll be helpful to give you an overview of what LSVT BIG looks like, just in case you're not familiar with that treatment, or maybe it's a treatment that you're considering but haven't yet received. So the delivery of LSVT BIG is always delivered by LSVT BIG certified physical and occupational therapists who have taken a specialized training course on how to deliver this treatment. They can either go to a live course or take it online. It's very easy for them to do so, but they have to have received the certification first. It's a one-on-one treatment, so it's not a group intervention. It's always an individualized treatment, and you'll see in a minute why that is. The time of practice for the LSVT BIG therapy protocol is 16 sessions over the course of 1 month. So it's delivered 4 times a week for 4 weeks, 1-hour sessions, one-on-one with your therapist. And on top of that, each patient has daily carryover assignments and daily homework so they can really get in the habit of practicing their bigger movement and integrating that into real world function on a daily basis. This is just a snapshot of what one of those 1-hour treatment sessions look like for LSVT BIG. You can see on the left side that there's a series of 7 what are called maximal daily exercises. I'll discuss those in a minute. On the right side, you see something called functional component tasks, hierarchy, and walking big. And that is really using those bigger movements and integrating them into real world functional activities. So we think of it this way, is that the first half of the session is really core exercises, which are building blocks to improve your movement, improve your amplitude, balance, range of motion, and many other things. And then learning how to use that better and bigger movement in functional tasks, which are very specific to each person. So the functional tasks that you might want to work on could be quite different than the ones that other people that you know have Parkinson's want to work on. This is just a slide which shows a picture of all 7 of those exercises. And you can see as a whole that the model, Jenny here, is using big movements, whether it be her arms or her fingers, her hands. Her fingers are all spread apart. Her leg movements are big movements. And the reason this is to really target those small movements called hypokinesia that are typical for people with Parkinson's disease. So you can see that 2 of the exercises, she's sitting in a chair and she's really holding that position to work on posture and a lot of stretching. And the other exercises are stepping exercises in which she steps different directions, forward, backwards, sideways, and rocking exercises where she rocks forward and backwards and side to side to really hit all the planes of function and movement that we use in everyday life. Now, as a note, those can be really adapted to meet the needs of many different types of people and their abilities. So for some folks, it's helpful to do the exercises in a different position, like hanging onto a chair or even sitting in a chair, or sometimes even lying in bed or on a firm surface to do the exercises. So in that way, they're very much individualized to every person that we treat through the LSVT BIG protocol. As a whole, the LSVT BIG exercises help with a number of things. The main thing that we really focus on and target is bigger movements to override that tendency to move too small. But by the nature and design of the exercise, you'll reap some other rewards, such as working on starting and stopping movement when you want. Sometimes people with Parkinson's have feet that want to get carried away and don't want to stop, which can cause freezing and falls. And other people have problems with initiation of movement. And so really those 2 things are built into the exercises. We work a lot on direction changes and turns with the exercises. We're always working on building up repetitions to increase endurance and stamina. The nature and design of the exercise promotes improvements in balance, in posture, and safety of movement. And those few things there I've highlighted in blue because those can be things that people continue to struggle with even post-DBS. So functional task-specific training in LSVT BIG is really, really important. We know that there's a number of research studies out there that really highlight the importance of exercise in people with Parkinson's disease. And LSVT BIG incorporates intensive exercise, but it doesn't just stop there. So it really trains people then how to use those bigger movements in function. So it could be tasks that are very different for each person. In this picture, you see the individual working on getting out of a chair. And we see a lot of our patients really have a struggle getting out of low chairs or soft or deep chairs like sofas. But it could be other things as well. And we'll talk about those on the next slide. Over time, we progress those tasks in complexity with the goal that each person would be able to really return to functional activities that are meaningful to them, whether it's related to activities at work, activities at home. Could be simple things like getting dressed, bathing, even getting in and out of bed or getting out of the car. So they're very unique to each person. And here's just some examples of some personalized, purposeful practice that we feel is very important for every individual. So you could see that it could be something like a fine motor task like buttoning, or something like getting your socks and shoes on. For this lady, she loves gardening, and so her therapist really incorporated on big movements to get up and down from the ground without needing help. to be able to bend over, use the clippers, etc. For other people, it could be mobility challenges, such as getting out of a car or getting out of a chair. So really, it's unlimited what kind of functional tasks that we can work on through LSVT BIG, as long as they're really meaningful to you. And that's very motivating for our clients. Throughout the LSVT BIG 1 month treatment, we assign daily homework. Part of this is practicing the exercises at home. Sometimes it's with a coach or a caregiver if needed. Sometimes it's with our LSVT BIG homework helper videos, which are seen on the right side. But the idea is to really get people in the habit of exercising if they haven't been exercising for a while. So we want people to maintain their function long term, and getting in the habit of exercising daily and remembering how those bigger and better movements feel in real life is an important part of that. Our patients also get daily carryover assignments where they really practice using those bigger and better movements outside of therapy in a variety of real world situations. So your therapist might assign you a task of, using your bigger movements to open the door into your car, or it might be something more complex, like using your bigger movements to negotiate through a crowd in the shopping mall during the busy Christmas shopping season. Our goal for all of our patients that have Parkinson's disease is what's called sensory calibration. And what I mean by that is there's an underlying sensory disorder in all people with Parkinson's where they don't recognize just how small their movements have become. And through intensive training and feedback, our goal is that our patients will recognize and accept the amount of effort needed to move bigger and better, and by better I mean more normally, this way more automatically in everyday life. After LSVT BIG, our patients continue to do their exercises on a daily basis, lifelong. They can participate in group exercise options. We have one specifically for LSVT BIG patients called BIG for Life. This is a community-based exercise class. And just like you go to the dentist every 3 to 12 months, we also have what are called tune-ups with your LSVT certified therapist every 3 to 12 months as well. On top of this, we always encourage other fitness options that you enjoy. So that's really a snapshot of LSVT BIG and our lifelong model of care. DBS may be part of that journey for some patients that we see as LSVT BIG clinicians. And so in these next few slides, we really want to highlight how we use LSVT BIG before and after DBS. So you might be wondering, first of all, when should I do LSVT BIG treatment? Should I do it before or after? And what we'll tell you is that there's no right or wrong, but we'll tell you the rationale for why you might want to consider it both before and after DBS actually. So before DBS, it's really beneficial to maximize your functional level with exercise. If you're kind of on the fence or not sure yet if it's really time to do DBS, or if you could hold off a bit longer with that. So of course, it's an invasive option to do brain surgery, and if you can improve your function through therapy, that would be very desirable. We know through research that exercise really is medicine, and we have seen both clinically and through our research studies that function can improve greatly beyond what medicine can do through therapies like LSVT BIG and LSVT Loud. We also want to really optimize a person's gait and balance and physical fitness and wellness before a planned DBS. So as Heather mentioned, sometimes balance can be negatively impacted post-DBS. So it stands to reason that we would want to, really optimize your balance and your walking as much as possible, really get you in the best shape possible prior to surgery. Also, as therapists, it helps us to establish a baseline of function and activity before surgery so we can compare. After DBS, LSVT BIG can really be very beneficial to assist if there are persistent balance issues and to retrain appropriate motor control for movement. Also, we work on maximizing functional abilities with a combination of therapy and surgery. So before LSVT BIG, before DBS, let's dig into how we would use LSVT BIG just a little bit more. Before DBS, most of our patients, especially those that are considering DBS, are having changes in their movement. The movement might become smaller, slower. They might be having difficulty with freezing of gait, and some of the side effects like dyskinesias might also be impacting their function negatively or their safety with function. And so prior to LSVT or prior to DBS, we would really use LSVT BIG in a way we would for any person that has Parkinson's, focusing on increasing amplitude to restore movement with function in everyday life. Also restoring balance and functional abilities. We would collect those outcomes so we can compare pre and post DBS to see changes either positive or negative related to function, gait, and balance. After DBS, as Heather mentioned, balance deficits may persist, and they may also be increased in some people. And as you saw in the snapshot of those exercises, and perhaps you've already had LSVT BIG, you can see that all of the exercises are very challenging from a balance perspective, and thus they can really improve a person's balance and overall motor control. People with post-DBS continue to need repetition to learn appropriate amplitude and motor control. And as Heather stated, people have less rigidity and increased freedom of movement. It takes less effort to move than it did prior to DBS, but underlying there's still significant sensory and proprioceptive deficits, and so it could become difficult to learn how to control these new movements. And so that's what we can really help with post-DBS, is to use those exercises and that functional training to work not so much on increasing amplitude, but learning how to control the newfound movement and newfound amplitude that they have. And it really takes a lot of training and repetition of practice so that the person with Parkinson's who's gone through DBS understands that, hey, it might have taken me an 8 out of 10 effort to walk across the room pre-DBS, but now I know I can do it with only a 2 out of 10 effort, but I really have to work on my control and walking in a certain way. Lastly, we know that freezing may persist post-DBS, and LSVT BIG is one intervention that we can really look at where are you freezing? When are the times of the day that you are freezing? What are those triggers? And we can incorporate them into the LSVT BIG treatment session to really customize the attack of those freezing issues that you might be having post-DBS. Before you start therapy, it would be important to make sure that the DBS settings are stable so that if you know that there are any changes in movement, namely improvement in movement, you understand if it's coming from the DBS or from therapy. Of course, the patient also should be healed enough in terms of the lead placement and also the what I call the pacemaker placement in the chest, so that they have freedom of arm movement without worrying about displacing that controller. And lastly, the patient and therapist relationship is really vital post-DBS. The neurosurgeons and neurologists that have close relationships with therapists really appreciate the feedback that you give as therapists to inform of how a patient's movement is going, if you're seeing any changes or any negative effects that might impact how they change the programming settings the next time that they see the patient. So in summary, there's some really important rationale that exists for providing physical and occupational therapy, including LSVT BIG, actually before and after DBS. There are some motor control issues that may still exist even post-DBS, despite improved movement and reduced rigidity and reduced tremor. The therapist might need to focus more on control of amplitude versus increased amplitude post-DBS. And people with PD who have had DBS might still have balance issues and possibly even increased fall risk that will require therapy. And so our summary statement really is, for those people that undergo DBS, we know that it can be very helpful in a number of things, but it doesn't negate the possibility that you'll need therapy and could benefit from therapy. And we are here to help you if you're a person with Parkinson's who's joining us today. Our next slide, we just wanted to provide you with some links and resources that we have found really good. One of them is a surgical options, a treatment guide for Parkinson's disease. The website of parkinson.org that really talks about DBS more in depth. The APDA also has some nice resources, and we pointed you here to their webpage that talks about DBS. And lastly, the Veterans Health Administration has come out with a number of really wonderful videos, and this one is called DBS and PD, and they provide valuable insights not only from the patient, but the physician and others that were impacted by the DBS surgery. If you are a person with Parkinson's and you're looking for an LSVT BIG certified clinician, it's very easy to do so by going on our website, finding the big orange button at the top of the page that says Find LSVT Clinicians. Enter your location, select which therapy type you want, click on the Agree to Terms and Conditions, and then ask your doctor for a referral to one of those clinicians, and they would be happy to see you. So at this time, we're going to prepare to ask some questions and answer some questions, and I've just written the instructions for asking your questions here again. You can type them into your control panel, and I think that we've already had a question or two come in, so thank you for that. You can raise your hand. Remember, you can click on the hand icon, and I'll unmute your microphone and let you know that it's your turn to ask. Or you can always email us at any time at info@lsvtglobal.com if you think of questions later. So with that, I'm going to open up for questions. And the first one I see here is the matter of programming the device is not well known. Who is doing the programming and what skills are being utilized? Heather, do you want to take a shot at that one?
Sure, absolutely. It isn't just the neurosurgeon. So your neurologist, your nurse practitioner, there are different people, and they are specifically trained through the companies that actually make the devices, Medtronic, and I believe the other one right now is St. John's. Don't quote me on that. But they get extensive training on how to actually tune those up. So it could be a different person each time that you're going to, and it could be someone of a different profession, but it isn't just the neurosurgeon who does that. Most likely it'll be your neurologist or a nurse practitioner.
All right, thank you, Heather. Another question that came in earlier via email was, do you have any tips on driving and sustaining the effort for patients with DBS? And I'm assuming this is a therapist that is writing us.
Yeah, so another great question. So yes, even though someone has had DBS, there's still going to be those issues underlying from the actual disease process. So it's not going to differ a bunch. I'm going to talk about how it could differ if people are moving too big. But in general, the therapist really needs to have high energy, high intensity, not only using your voice to drive people and stimulate them, but also by you acting out those movements by using your modeling. So you really need to show those big hands and that big posture and those big steps. I think one of the most important things you can do is you're always linking back why you're doing what you're doing and how it's going to improve the person with Parkinson's quality of life and their functionality. So, we're doing this exercise because this one, when you make this big, this is how I want you to be able to reach into the cabinet big. Or when we do this exercise, this is the same kind of step that I need you to take when you're trying to get started out of an episode of freezing of gait. So I think being very cognizant of explaining why we're doing what we're doing and being very cognizant about how we are educating with our own body and our own voices. Now, for people who have had DBS who are actually moving too quickly and too big, that's where we're going to have to kind of modulate what we're doing as therapists, where we might have to move with better control, that we're being very insistent on the good control of the stops and the starts, and we're using LSVT BIG to actually help that patient control their movement or dampen down the excessive incoordination that they're having. So it can come from two areas, but I think underlying everything is always going back to why are we doing what we're doing and how is this helping me to improve my quality of life and to improve my functionality.
That's awesome. Thank you, Heather. The next question that came in was LSVT BIG would be helpful to a person with PD without a plan for DBS, and why are neurosurgeons not typically encouraging the training? And thank you for that question. I'm happy to answer, and I'll let Heather put in her 2 cents worth as well. So you're absolutely right. LSVT BIG is extremely helpful to people with PD without a plan for DBS. And I think as with any profession, you'll find neurosurgeons and even neurologists who are very aware of these therapy interventions, and some simply aren't aware for whatever reason. And so if you're a person with Parkinson's or a caregiver or even a therapist working in a system where they do DBS, I think it's always good to be an advocate and bring up the question of, what about therapy? It's easy to find an LSVT certified clinician through our website. It's really sent as just a regular physical or occupational therapy referral that says evaluation and treat. And for most people, therapy is also covered by their medical insurance, especially Medicare is quite good about it. So it's good to speak up and inform and share information and resources with people that might not know about these treatment options like LSVT BIG and LSVT Loud. What I found in my personal practice is that I haven't fortunately found people that are against therapy. I've mostly found people that are uninformed and don't know about the value of therapy and just the amazing gains that people can make through therapy. Heather, do you want to add anything to that?
Laura, I think you hit all the points. I think it's sometimes, people just aren't educated about what the other options are that are out there. Sometimes, the surgeon may be kind of living in the surgeon's world and they're thinking of everything from that standpoint. So I think it behooves us as the people who specialize this and as the people living with Parkinson's to make sure that we're educating everybody involved in our care.
Great. And, the other thing that came up as you were talking earlier, Heather, was about your DBS clinic and your DBS team. And I think that's a beautiful model of care. And I hope that every center that does DBS has a clinic and has a really close-knit team like that, because the coordination that it takes to really make these types of really important decisions and continue to help people whether or not they have DBS is so crucial. And I just appreciate working on a team like that, where everyone's input is respected, whether you're an allied team training member or a therapist or a physician or whatever it is. So if you're a person seeking DBS, I would recommend that you always seek out a place that has that really tight-knit interdisciplinary care team that will help you with those needs before or after DBS. Okay, with that, I don't see any other questions coming in at this time. I'll give it one more minute while I'm going through a couple of last slides. Just a reminder that we have some upcoming LSVT BIG training and certification workshops. So if you're a PT or an OT professional or student, that includes assistants as well, and you're looking to get certified, these are some that are coming up in 2020. Of course, we have more on our website for later in the year. And if you're a person with Parkinson's or a caregiver or a family member, we would just love to have you come to these seminars. On the second day of our workshop, where we're actually training and certifying clinicians, we have these 2-hour free seminars from 12 to noon always, where we invite people to come and learn about what LSVT BIG is through a 1-hour lecture, followed by a 1-hour interactive exercise time. It's so fun because all of the clinicians who are getting trained in LSVT BIG can interact with the volunteers that have Parkinson's, and it's just a real win-win fun situation where we can all learn from each other. So if you want to learn more about that or join us for one of those free seminars, if you're a person with PD, I put the web link for our blog here where it tells more about that. If you have any other questions at any other time, always email us at info@lsvtglobal.com, or you can call us, or we have a ton of information on our website and blog as well. We would love it if you would register for our next upcoming webinar in December. That'll be Wednesday, December 18th from 2 to 3 p.m. Eastern Standard Time, and it'll be on a research and talking about all the clinical updates in both LSVT Loud and LSVT Big that we've really encountered and learned about over the last year. The last slide is this. We've just listed some references for our webinar today. If you want to dig in and learn more, of course, please look on the slides themselves, because you'll see web links to APDA and other resources like parkinsons.org, where you can learn more as well. So we thank you for joining us for our webinar today, and we hope to see you back in December. And thank you, Heather, for contributing as well.